afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on syphilis in Ontario, a clinical and surveillance update. My name is Laura Borns, and I'm the public health physician at PHO, and I have the pleasure of moderating today's session. Before we begin today's presentation, I'll mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of the session, I do not have any potential conflicts of interest. It is now my pleasure to introduce the speakers for today's sessions, Andrea Saunders and Patrick O'Byrne. Andrea Saunders is a communicable diseases specialist with Public Health Ontario's Health Protection Department. As a nurse epidemiologist, her work encompasses a variety of activities related to public health surveillance and management of infectious diseases, with an emphasis on TB, influenza and emerging respiratory pathogens, and sexually transmitted and bloodborne infections. Andrea is a graduate of the Canadian Field Epidemiology Program and has also completed postgraduate training in tropical nursing and public health at the London School of Hygiene and Tropical Medicine. Andrea does not have any conflicts of interest to disclose. Patrick O'Byrne is a full professor of nursing and a licensed nurse practitioner. Dr. O'Byrne's research and clinical work focus on the prevention, diagnosis, and management of sexually transmitted and bloodborne infections. As part of this work, Dr. O'Byrne has implemented a community-based nurse-led HIV post-exposure prophylaxis and pre-exposure prophylaxis clinic in Ottawa. He is also the principal investigator for the Get a Kit project. Dr. O'Byrne has a relationship with a for-profit and a not-for-profit organization, the Ontario HIV/AIDS Advisory Committee and the Ontario HIV Treatment Network. The learning objectives for today's session are as follows. By the end of the session, participants will be able to describe current trends related to infectious syphilis in Ontario, including those related to women with infectious syphilis and congenital syphilis cases. Identify opportunities to improve syphilis surveillance data, particularly with respect to congenital syphilis. Third, discuss the clinical and public health management of infectious syphilis in Ontario, including testing, staging, treatment, and follow-up monitoring. And lastly, apply infectious syphilis public health management approaches to case scenarios.
So I will get things started today by describing a bit about the epidemiology of infectious syphilis in Ontario over the last 10-year period. So just before I begin, for those of you who may not be familiar with infectious syphilis, this refers to individuals who have been diagnosed with syphilis at either the primary, secondary, early latent, or infectious neurosyphilis stage, which are the stages that are considered to be transmissible. And as I'm sure many of you are more than aware, the recent COVID-19 pandemic has had significant impacts on the healthcare system in Ontario. So as a result of that, we've seen challenges with access and availability of healthcare, differences in health-seeking behaviors over the last couple of years, as well as public health capacity and follow-up for case entry. So just to bear that in mind as we interpret some of the data over the last few years, that data from 2020 and 2021 and going forward into 2022 should be interpreted with caution as a result of this, the impacts of this pandemic. As well, the data that I'm going to be presenting has been taken from our provincial electronic public health surveillance system, also known as IFIS, and these data were extracted on June 29th. And the population data that has been used to calculate rates per 100,000 population have been provided by Statistics Canada. And we are using population estimates from 2020 to calculate rates for both 2020 and 2021, as the 2021 estimates have not yet been made available. So if we look at the rates of infectious syphilis over the last 10 years in Ontario, we can see that beginning in about 2013, we have seen a steady increase in both the number of cases and the rate of infectious syphilis in the province, with the overall provincial rate nearly tripling in this 10-year period from a rate of 6.3 in 2012 to almost 20 per 100,000 population by 2021. The vast majority of cases have been reported among males, and they continue to experience the highest rates per 100,000 population. However, what is striking is that in these last 10 years, the proportion of infectious syphilis cases reported among females has grown significantly. So back in 2012, females accounted for only 3.2% of all infectious syphilis cases reported in the province. And as of 2021, they now account for almost 15%. And along with this increase, their rate per 100,000 population among females has increased dramatically from 0.4 in 2012 to almost 6 cases per 100,000 population by 2021, which represents a rate increase of over 1,300%. If we look at diagnoses by stage among males over the last 10 years, you can see that the proportion of cases that have been reported or diagnosed at the primary syphilis stage have remained somewhat stable at approximately 30 to 34%. However, during this time, you can also see that the percentage of cases reported as secondary syphilis have decreased over the last 10 years, with a subsequent increase in the proportion of cases being diagnosed at the early latent stage. And in 2021, that accounted for approximately 37% of all cases among males were diagnosed at the early latent stage, which does suggest a possible delays in diagnosis. And among males, less than about 1%, 1 to 2% of cases are diagnosed at the infectious neurosyphilis stage. When we look at the similar data among females, it is a little bit more difficult to interpret over the last 10 years, given the relatively smaller proportion of cases among females. However, you can see that some of the trends observed among males remain true within females as well. So we do see a relative stabilization of cases reported at both the primary and secondary stage. And we also see that the majority of cases among females, or almost 40%, have been diagnosed at the early latent stage. And although the proportion diagnosed as infectious neurosyphilis is also only around 2.5%, it is interesting to note that a slightly higher proportion of female cases have been diagnosed with infectious neurosyphilis compared to males. When we look at the rate increases by age group, we can also see some steady, dramatic increases among males across almost all age groups. And as you will see in the subsequent slide, among both males and females, the vast majority of cases are diagnosed among those 25 to 39 years of age. So over the last 10 years, the rates have been highest among these 3 age groups. And between 2012 and 2021, all 3 of those age groups experienced a roughly 200% increase in their rate per 100,000 population. However, what is most interesting to note is that although it may be slightly difficult to see on this slide, the age groups with the actual highest percentage of rate growth over the last 10 years have been those in the 50 to 59 and 60 plus age groups, with those 50 to 59 years of age experiencing a rate increase of over 300% during this 10-year period. When we look at females by age group, you can see that the rate of infectious syphilis among females started to really increase between 2016 and 2017 and has continued to steadily climb up until the last couple of years. And again, we do see the highest rates reported among those in the 25 to 39 year age group. However, among females, it is those in the 25 to 29 year age group that have the highest rates in both 2021 and also experience the highest rate growth. So among that age group, in 2012, the rate was 0.2 cases per 100,000 population, and by 2021, it reached 16.5 cases per 100,000, which represents a rate increase of over 8,000%. This slide just shows again the age groups by sex with both plotted on the same curve. And here again, you can see that among both genders, the vast majority of cases are reported among those 25 to 39 years of age, with among males, the highest rates reported among those 30 to 34. And you can see quite a sharp increase in the rate up until that age group, and then a slight decrease as individuals get older. And among females, with the dark green line, you can see that, again, the rates are highest among those 25 to 39 years of age, but the rates are fairly stable or plateauing among that age group. And finally, if we look at the rates of infectious syphilis by geography, we can see that here among our 34 public health units, we have one health unit, that Temiskaming, that did not report any cases of infectious syphilis in 2021. And it's interesting to note that almost half, or a further 17 of our 34 provincial public health units reported an infectious syphilis rate of less than 10 cases per 100,000 population in 2021. And as you can see, the highest rate of infectious syphilis in the province last year was in Northwestern. They had a rate of 57 cases per 100,000 population, but it's important to note that this does only reflect 50 cases, which is almost 2% of the provincial total of infectious syphilis cases. But given their relatively smaller population, it results in a higher rate per population. And Toronto Public Health experienced the second highest rate in 2021 and accounted for almost 50% of all infectious syphilis cases reported during this year. And a further 5 public health units, including Hamilton, Niagara, Thunder Bay, Waterloo, and Kingston, Frontenac, and Lennox-Addington, experienced rates between 20 to 30 cases per 100,000 population. Now, if we switch our attention to early congenital syphilis in Ontario, we can see an alarming trend in the number of cases and rate of early congenital syphilis in the province. So you can see that between 2012 and 2018, provincially, we averaged between 1 to 2 cases of congenital syphilis each year. However, this number has sharply grown over the last 3 years, with 3 cases, 5 cases, and 8 cases reported in 2021. And as you can see for 2022, based on data that was pulled on June 29th, so just 6 months into the year, we are already at 7 confirmed cases of congenital syphilis at the midpoint of the year. So we do continue and expect to see that number continue to increase over the next several months. And if you overlay the rate of early congenital syphilis in Ontario with rates of infectious syphilis among women of childbearing age, so looking at those specifically between 15 to 39 years of age, you can see that there is a sharp correlation between the significant rate increase among females between 2016 and 2021 and the corresponding increase in congenital syphilis cases from 2018 onwards. If we look at both of these by geography again, we can see that, again, the highest rate of infectious syphilis among females of childbearing age is in the northwest of the province. They had a rate in 2021 of almost 200 cases per 100,000 population in this year, followed by Waterloo and Thunder Bay health units, which had rates between 30 to 50 cases per 100,000 population, and a further 5 health units, including Middlesex, London, Niagara, Kingston, Hamilton, and Huron-Perth, had rates of infectious syphilis in this age group between 20 to 30 cases per 100,000 population. However, it is interesting to note that when we look at the cases of congenital syphilis by geography, the health units with the highest burden of infectious syphilis among women of childbearing age does not necessarily appear to overlap with where our congenital syphilis cases are being seen. However, again, it's important to note that we are dealing with very small numbers of cases. So in 2021, we had 8 cases of congenital syphilis, 4 of which were reported in Hamilton, 2 in Durham, and 1 in each of Peel and Niagara. So obviously this increase in both infectious syphilis among males and females and the corresponding increase in congenital syphilis in the province is clearly of concern and should be a priority for public health moving forward. However, there are many gaps and challenges with improving surveillance for congenital syphilis in Ontario. For example, we do have a lack of sufficient data to adequately describe both maternal syphilis and cases of congenital syphilis in the province. In IFIS, which is our electronic public health surveillance system, congenital syphilis cases are often not linked to the maternal case, or the maternal case has not been confirmed or entered in the system. If the maternal case is available, there are often a lack of reported risk factors or any information regarding pregnancy status and or access to healthcare during pregnancy. And part of this is an issue with the infrastructure of how IFIS is set up and the available risk factors for health units to be able to select and enter data, but also with challenges in reaching clients who have been diagnosed with maternal syphilis and obtaining that information and getting it entered into our system. So some of the strategies that we've been considering in the province going forward is to work on improving our data entry in IFIS. So this includes updating, making sure that all maternal cases get entered, that pregnancy status is updated, and that these cases are linked to the congenital syphilis case, if that is the outcome of the pregnancy. We would also like to look at enhancing the surveillance of risk factors, including a possible linkage to the OnMarge data set, which for those of you who may not be familiar, is a data set that's based on demographic characteristics captured in the Canadian census and includes dimensions of marginalization such as economic, ethno-racial, social, and age-based marginalization. So linking our cases to that data to obtain some further information on where our cases are coming from. We could also consider conducting detailed case reviews of recent and future cases of congenital syphilis, and also explore potential changes to our current provincial case definition for congenital syphilis and data entry practices as we potentially move some of our additional communicable diseases into the case and contact management system that is currently being used for COVID and maybe undergoing an expansion over the next few years. Some of these opportunities have been identified through a jurisdictional scan to look at what other areas have been doing with respect to congenital syphilis and maternal syphilis. And some of these jurisdictions have also been conducting enhanced surveillance, as I mentioned earlier, including case reviews and routine or quarterly reporting of maternal syphilis and congenital syphilis data to keep both public health and clinical practitioners aware of the burden of syphilis in our province. So with that, I will say I'm happy to take questions after Patrick's had an opportunity to present his content. But if you do have any questions going forward, please feel free to reach out to us at the Communicable Diseases team at this email address. And with that, I will turn things over to Patrick.
Excellent. So I've already had the introduction done. My name is Patrick O'Byrne. I'm a full professor of nursing at the University of Ottawa and a nurse practitioner who works within the sexual health clinic for Ottawa Public Health. But just as a quick clinical overview, many of us come from different areas, have varying degrees of familiarity with syphilis itself. So it is a bacterial organism caused by Treponema pallidum. Transmission is through both direct contact with the organism through infectious lesions. So this could be chancres, this could be manifestations of secondary syphilis, such as condylomata lana. This also could be through bodily fluids when the individual who has syphilis is bacteremic, so when we actually have an active infection going on. The estimated risk of transmission is high, right? 30 to 60% we see actually emerging. And this is very interesting when it comes to actually dealing with people who are contacts, right? We benchmark this against HIV, where we estimate the risk of somebody who has transmissible HIV to be anywhere between sort of 0.05% to a max of 3%. we're looking at 30 to 60%. So the risk of onward transmission per contact per relationship is actually quite high. The symptoms of syphilis, it is known as the great imitator, the great masquerader. So expecting it to look like anything is always important. We have classic textbook descriptions and definitions of syphilis, but they often are not what we see in clinical practice. These phases, though, are divided into sort of 4 discrete stages, and we'll get into that a little bit more. For screening, who do we actually want to test? Following the antenatal record, Andrea made this perfectly clear. We have seen an increase, right, among women. We have seen an increase among prenatal cases, an increase in congenital cases as well. And so ensuring that antenatal record guidelines are being followed, right, so that's at the baseline with the CBC and the RH factor, Hep B, right, all of this being done at the sort of intake, that's being done. And then those in the 3rd trimester who have risk factors also being rescreened. Also to remember to screen people who have risk factors for syphilis acquisition, new partners who have symptoms, and by epi, right? So the groups that are most affected. Historically, as we just heard, this was mostly men who have sex with men, but with changing epi, we really have to make sure that we branch out and sort of include other groups as our epi changes. So the main first classification for syphilis is whether people have symptoms or not. And this is clear. We see this quite a bit in Ottawa Public Health. To be primary, secondary, or neuro, you have to be symptomatic. And it's not unusual for us to have reported to us asymptomatic primaries, which is not something that's actually in existence, right? They must, in fact, be symptomatic. The primary is a localized lesion that occurs at the site of inoculation. The organism buries into or gets into the skin and starts causing an infection. The key point here is that it's a localized lesion. You don't necessarily have antibodies developed. You don't have any systemic symptoms or dissemination. After that, the infection does disseminate. It goes throughout the entire body, and you get classic seroconversion symptoms, flu-like symptoms, lymphadenopathy, rashes, lesions, fatigues, myalgias, arthralgias. All of these can manifest as the secondary. Neurosyphilis is possible, and people often think of neurosyphilis as you've had this for a long time. It's a manifestation of tertiary syphilis. But if you look at that sort of image I have just beside the text, it's actually known that around 25 to 60% of individuals with primary secondary can develop early neurosyphilis. This is different from the late irreversible damage of tertiary neurosyphilis, but it is still a requirement for LPs, for follow-up, for IV treatment. So it's just to say neurosyphilis is not possible because it's not at the end. It is actually quite possible directly from or concurrent to primary or secondary syphilis. So just to remember that. Then we go into the asymptomatic, the latent phase, which is rather arbitrarily divided around 12 months into early and late latent. Early latent is less than 12 months, but asymptomatic, and late latent is more than 12 months and asymptomatic. To be early latent, we really have some tight criteria. This is both by diagnoses and by Appendix B of the public health standards. The infection must be less than 12 months, and this would be somebody who is asymptomatic, has new labs, and is a contact, has a change from a baseline negative lab, or has a change in their RPR, so the non-treponema quantitative test, by a minimum of 4-fold. So any of these would in fact qualify. Anything beyond that really starts as late latent. And clinically, where I start with this is I will always start with saying this person has neurosyphilis. Then, in the absence of any neurosymptoms, move back to they have late latent. And then if I can move into no, they do have symptoms, are these symptoms of primary, these symptoms of secondary, or if they're asymptomatic, can I actually fulfill one of the early latent criteria? So my approach is, instead of saying, well, I've got these 4 stages that I need to work with, is to really say clinically and through our public health staging practice, all right, we have this case. Let's start with worst case scenario. You need to go for an LP and have IV penicillin, and slowly you work back from that. And it's quite simple to do, right? There's no neuro symptoms. There's no indication for neuro. You can remove that out. Now it's late latent. So we really want to be giving the 3 doses, right? But then we say, no, this person is a contact, or they do have the negative labs, or on exam, we did identify a chancre. Then you're able to move back from what is the longest amount of treatment and most management that's possible into that which is much smaller, as opposed to erring on the side of under treating or under managing somebody. So I really like to say, if I'm going to be wrong, I would rather be wrong on the side of giving somebody 3 doses rather than 1 dose of penicillin to make sure that everything's managed. Now, for the symptoms themselves, that chancre we talk about, the single indurated, non-exudative genital lesion that is painless, is pathognomonic for syphilis. You see that 98% specific, you are looking at syphilis. But the fact that the sensitivity is listed as 31% really tells us that 2 out of 3 times syphilis looks nothing like, or at least the chancre looks absolutely nothing like what we always say it looks like. So knowing that when we see this syphilitic chancre, we can be confident in knowing what it is. We also need to recognize that those symptoms should not preclude us from accepting other things or having a high index of suspicion that other genital lesions or genital markings could as well potentially be syphilis. The rash equally can be diffuse, it can be subtle, it can be stuff that we don't typically expect. And notably, individuals who are sort of the receptive partner, the individual being penetrated during sexual contact, whether this is men who have sex with men or women, most often the presentation is actually secondary due to the fact that if this lesion is in fact painless and the site of inoculation is on the cervix, it's on the inside of the vagina, it's in the rectum, the ability to locate, to look for, to even know that a painless lesion exists on somebody's cervix or in somebody's rectum is exceptionally small. So it's not surprising that we will miss a lot of primary infections in these cases, and that individuals will actually present more so into the secondary phase. So looking at the data to say we're getting more secondary is not necessarily meaning that we have delays in access to care. I do think those exist. However, it could also just be with the shifting demographic and the shifting epidemiology that we're looking at for syphilis. We know the groups that it's moving into are more often, many times for biologic reasons, diagnosed in secondary, just due to the fact that we can't visualize or even notice that a primary lesion is there. Now, really compounding all of this is we now have monkeypox. And looking at these images, you can see that monkeypox additionally is clinically indiscernible in many cases from syphilis. The chancre and the actual pox lesion between the top and the bottom are difficult, very challenging clinically to differentiate between. Regional, localized, generalized lymphadenopathy, rashes, mostly affecting gay, bisexual, and other men who have sex with men, means that we have these sort of current epidemics or outbreaks or emergences of rashing and lesion conditions, both within the same group. And so, this will cause some potential issues, but it could also be an opportunity for us to say, not all lesions, not all rashes or syphilis, they could also be monkeypox and vice versa. Make sure, that you go in for screening as you present with this. The testing here, a key point for us to look at is remember that the EIA, so what we screen with in Ontario, is only estimated to be around 75% sensitive within the primary phase. So somebody with a lesion and risk factors who has negative serology does not definitively rule out syphilis. This is, again, if it looks exactly like syphilis, it should be managed as such. But just to say that the lesion, just because the lab is negative, doesn't actually rule out syphilis. You need to put this into the fact that there could be a 1 in 4 false negative rate, and rescreening would be negative. Also should defer to some clinical acumen to say, if this lesion really does look like a syphilitic chancre and the labs come back negative, it's important to have them repeated. It's not a small number of times where an individual will come in as a contact. I have seen chancres or have had the person asymptomatic. We've treated follow-up labs a month or 2 later have actually yielded inconclusive results, sort of suggesting to us that at the time the person we had a false negative, we actually stunted their seroconversion by rapid prompt treatment. This is prevented the person from feeling unwell. They didn't have the dissemination and any sort of symptoms. It also is highly beneficial for public health, population health, in that we outright prevented any onward transmission. So benefits at both the individual and population level. The RPR, though, should in fact be virtually 100% sensitive within secondary. And really the only thing that would stop you from having total sensitivity is if the RPR is too high, it can flip back to a non-reactive, but this would be exceptionally rare. Most times though, a negative RPR in somebody with a rash could effectively rule out secondary syphilis. Doesn't mean they don't have primary, doesn't mean there's not something else going on and you just happen to have a rashing condition at the same time. There's also DFAs which are possible. You can submit to PHO, an actual specimen collection from the lesion. This is important. In Ottawa, we took one period to look at our cases, and we actually found that 14%, and this is a small number, you can see we're looking at just 29 people, but this was 4 of those 29 cases that we looked at were in fact serologically negative but DFA positive, meaning that they would neither have met case definition nor been followed for partner follow-up and case and contact management had we not done the DFA as well. So there is a utility in actually doing this. This is not an unusual atypical lab. It does meet case definition. It is within Appendix B to generate the powers, right, for public health units to actually act and follow up and do all of the work that we know works exceptionally well. It's just something to encourage either locally within your STI clinics, or right, just sort of community providers in your area to say, right, these lesions are important, knowing that we have that 25% risk of false negatives during primary syphilis. This is exceptionally important for us to look at. Staging syphilis, this is where people get a little bit more confused, and I put some labs there just to say you cannot stage based on labs. It's interesting because clinically you start with a patient, whereas in public health practice, right, particularly for reportable infections, we're starting with a lab. And so we end up with the lab, but we really have to go back and say syphilis staging is a combination of the investigations, right, that lab we receive, the physical examination, and the history. Does the person have risk factors? Does the individual have symptoms? Has the person had syphilis before? What exactly are we looking at in the lab? And you have to put the three together to actually come up with the stage. So it's not based exclusively on the lab result. I've said that yes, right, having a negative RPR could be pretty confident in ruling out secondary syphilis. That's just one thing though, right? It's not going to tell you if this is an early infection, if this is a late infection, and in either case, if this is an artifact of previous or recent treatment. So the labs in and of themselves are not sufficient. It's initiating investigations, it's following up with patients, following up with providers. Why was the test done? What are the risk factors of the individual? Were there symptoms? What did the history and physical exam yield? And putting that information together, right, as I have on the slide, to really say, here's what we have for the full sort of follow-up. The follow-up, the treatment is simple, benzathine, penicillin G. Getting to syphilis treatment is actually the easy part, and then the follow-up, as we know, recommended at 3, 6, 12 months for people with new infectious cases. Neither of those is complicated. The difficult part with syphilis is recognizing it, staging it, right, and then really from that naturally flows how much penicillin do you give, or doxycycline, and then when do we do the follow-up at the 3, 6, 12, or just at the 12 months, really what we're looking at. So more of the actual interesting stuff that we have. Inconclusive results are some special considerations. We took a look, this was 2019, we took a look at all of the inconclusive results that were generated into the jurisdiction of Ottawa Public Health and said what number of these actually warrant treatment. It's easy, and I think we all see quite frequently individuals getting conclusive results. The lab says we recommend you repeat these. And then, right, we sort of wait that 2 to 4 weeks before we repeat the lab. That's an interesting approach, but looking at it really came down to the fact that 50% of individuals who were reported to Ottawa Public Health in 2019 who had inconclusive results actually needed treatment. Remembering that the antibody levels for syphilis will start low, will go up, and will wane, and they will wane for one of two reasons. The first is naturally, right? People lose antibody levels. We're well familiar with this for the hepatitis B surface antibody dipping below 10 after a period of time. Syphilis does the same thing. So just with time, some individuals will, without treatment, naturally progress to inconclusive. Other individuals after treatment will also serorevert to an inconclusive status. So you could have, right, this is a very early infection. This is an old infection that's treated or untreated. Or lastly, we have the biologic false positive. But my experience has been that a lot of people jump on, well, it's probably a false positive, it's inconclusive, let's repeat, let's not do any action. But in an individual where you have a documented historical negative and a new inconclusive, particularly if they have risk factors, this is a sexually active guy who has sex with other guys, this is likely you're actually catching a very prompt infection. And so just from a public health standpoint, it actually is advisable for us to say, if this person, right, has risk factors, particularly if they have any symptoms, and a documented negative, would be to go immediately to treatment due to the fact that you could actually prevent onward transmission to other individuals. So it becomes important. Don't automatically assume inconclusives are false negatives. Don't necessarily say, well, I'm just going to wait the 4 weeks. It's again that staging process. What are the previous labs? What is the history? What are the risk factors? What is the epidemiologic profile of the individual? And based on the physical exam, what was found? Right? And then putting this together to say, in many cases, prompt treatment is required due to the fact that when you repeat it, lo and behold, yes, now you have, right, a full positive lab, potentially an RPR being present, and anyone that had sex within that period has now been exposed to syphilis. knowing the transmission, as I said at the beginning, ranges from 30 to 60%, right? We do have this sort of cluster of issues. And knowing as the context, which Andrea laid out really nicely for us, we have increasing numbers of syphilis, right? It just becomes sort of prompt and prudent for us to initiate treatment in many of these cases. Other special considerations, treatment. So this is the epi and empiric treatment. Again, the risk of transmission is high. So individuals who are contacts, please treat promptly as opposed to just doing blood tests and waiting for the labs to come back. If this contact was within the last 4 to 6 weeks, knowing that that's the window period, right, for our test to really be able to rule out infection, a negative lab doesn't mean the person doesn't have syphilis. And at a high rate, potentially up to 60% transmission, right, it becomes again prudent for us to do treatment. The CDC, the United States Centers for Disease Control, in its 2021 update actually went further to say that it is important, right, and just to read here, because early syphilis decreases transmission, public health standards now require healthcare providers to presumptively treat any patient with a suspected case of infectious syphilis at the initial visit, even before test results are available. So stronger evidence and recommendations coming out to say, don't defer treatment. We know it has individual and population level benefits. If there's any index of suspicion, it is appropriate to immediately try to recommend treatment. HIV testing is also important. We know there is a strong number of, or rate or proportion of co-infections. Local STI testing clinics through primary care, different venues that you have available. If individuals or in your local area testing is not available, just reminding people that rapid testing, rapid self-testing for HIV is now available and approved by Health Canada. There's really 2 ways to get this in Ontario. The first is an individual can order a kit. They are, though, you can see a little bit prohibitive based on cost. They cost around $55 to order. There is also the Get a Kit study, and with full disclosure, I do run this study, but it is funded by the Ministry of Health and the AIDS Bureau and the Ontario HIV Treatment Network. But through this study, individuals who are eligible, people who have risk factors for HIV, are able to order HIV self-tests for free to their home anywhere in Ontario. So recommending HIV testing. And what we'll do is really say, if that's not available, please refer people. They can do self-testing as well. Now, also part of the sort of co-infection rate and probability and increased numbers that we have for HIV is also considering PrEP. And so the CDC, as you can see in its guidelines, has laid out pretty clearly saying, studies have documented the risk of HIV acquisition among men who have sex with men within 1 year after rectal gonorrhea or chlamydia, 1 in 15 men, primary, secondary syphilis, 1 in 18. And so it's really saying that at the moment you diagnose somebody with syphilis, within 12 months, it's around 6%. So 1 divided by 18 is about 5.5%. So around 6% of men who have sex with men who are diagnosed with infectious syphilis will become HIV positive within 12 months of the moment you connect with them to do the case management follow-up, to do the actual clinical assessment follow-ups, treatments, So you're going to have a large number of people who will actually be HIV positive. So it's really saying this is a strong objective clinical indicator for people to need to actually be referred for HIV pre-exposure prophylaxis. For the rectal infections, you can see that rate's even higher. It's 1 in 15. Moving up to sort of 7 and 8% of men who have sex with men who are diagnosed with rectal gonorrhea. So to really put that into simple terms, it means that for in your jurisdiction, 1 out of every 15 guys who have sex with guys who your case management team follows up with, or your clinical team follows up with for a rectal gonorrhea infection, 1 out of 15 of them will potentially be HIV positive by the end of a 12-month period. So that's a strong risk factor. PHOL has actually gone so far as I've really copied there out of the actual bottom of a requisition. The note that now says on all PHOL rectal infections among men, the rectal bacterial STIs have been associated with an increased risk of HIV infection, in GBMSM and transgender women. Screening for HIV and initiation of PrEP for HIV negative individuals is highly recommended. So at this point, I would actually go so far as to say that with all the evidence we know between the links between infectious syphilis and rectal infections, and HIV, it sort of gets to the point where it burdens or it borders on being negligent for us to not offer PrEP at the point that we have, right, a guy who has sex with guys who is diagnosed with infectious syphilis. We know it's a risk factor. We know 5 to 6% of these guys are going to be HIV positive, potentially within 12 months. So it really becomes incumbent upon us as both clinicians, right, and practitioners within health units to say, okay, how do we actually use syphilis, not just as the infection we need to manage, but also as that risk factor, that clinical objective indicator to say, right, there's more management that we can do, and how do we recommend, encourage, and refer for people for PrEP as part of our public health work. In Ottawa, we have specifically developed criteria, and infectious syphilis, you can see, is there. And really what we do is anyone who is a contact of somebody with transmissible HIV, so really new diagnoses where individuals are not on medication, contacts of people who were diagnosed with infectious syphilis, individuals who were diagnosed with infectious syphilis, people with rectal bacterial STIs, we will offer a referral for PrEP immediately through our case management process. And we built this into the pro forma, the standard follow-up that our case managers at Ottawa Public Health do. And just say, right, did you get your treatment? Have we notified your partners? Also, PrEP, is that something you're interested in? And if so, right, how do we actually have a standard referral process set up? So it just adds in that one more piece of conversation to say these infections are not isolated, right? They are all linked together. They are risk factors and indicators of referrals for other infections. They're the thing that shows up first in some cases to tell us there's actions we can take now to actually help us address HIV moving forward. And Ottawa, unsurprisingly, we've seen this in London, England. We have seen this in New York City, within San Francisco. Many cities, actually, the entire, it's New South Wales in Australia has also demonstrated this. Systematic referrals for PrEP, particularly focusing on syphilis, really do actually drive down HIV diagnosis rates. That drop, everyone talks about the drops occurring in 2020. You'll notice that the rates of HIV, in fact, dropped pre-COVID in Ottawa. While you compare this to the rest of the province that actually climbed up anywhere between 1 to 4%, we actually have here, right, a drop in Ottawa by around 30 to 40%. Almost exclusively made up among gay, bisexual, and other men who have sex with men. And a lot of this came from us focusing on these guys who were diagnosed with infectious syphilis, offering them PrEP right off the bat at the time of their diagnosis, or being notified as a contact to say how many of you would actually like to take PrEP. And people say, I didn't really know about this. This is not something I was fully aware of. And so instead of passively relying on individuals to come to us to request PrEP, in this case, we're actually offering it as part of just our standard work. So pregnancy. Now, this is also the key thing for pregnancy, is the next special consideration, is that late latent, which is typically considered as non-infectious for sexual transmission, does still pose a risk for vertical transmission. So some people will think, well, we don't need to, as public health units, do follow-up on late latent cases. It's a lot of work. We don't get anything. Women who are pregnant, right, there is still a risk of onward transmission, and this will directly relate to our number for congenital cases. So as per the antenatal guidelines, right, this should be done in the first trimester for absolutely everyone, repeated in the third trimester. I would go so far as to suggest that doing screening in each trimester if there's any risk factors, right, ongoing sexual contact, new partners, sex work, anything whatsoever with a low sort of threshold to do this is right, a prudent approach, particularly with us seeing the increase in the number of congenital cases. At the moment, though, that we actually do have a prenatal case, there's 3 referrals really that need to occur. Do health units, case managers, public health staff need to be doing this? No, but this is what the individual actually requires. And so whether the health unit individually wants to have any involvement in saying, let's make sure all 3 of these occur or not, I'd say relies on the health unit, but this is really what the individual needs. You would want a referral to a high-risk OB. You want pediatric ID involved right at the time of birth to do the assessment, and adult ID to actually do the treatment. All of these, though, and the assessments and the sort of in-depth detailed sonography, ultrasounds, right, all of that should not defer treatment. Treatment should be initiated immediately. And my threshold for treatment is, again, as always, which way would I rather be wrong? Would I rather withhold treatment because I'm not 100% confident that it's required and potentially put the fetus and the baby at risk for congenital syphilis, or would I rather recommend treatment and then say potentially we gave you some penicillin that you didn't need, however we're more confident, right, that there's no risk for congenital syphilis. And so I will really withhold exclusively if we have all of the following. right? We have the correct stage, we have the correct treatment, then there were no spaces of treatment. We can typically say that, right, up to 14 days between doses are fine, but we really want to reduce this to around 9 days, sorry, for individuals who are pregnant. An adequate drop in RPR for the stage, and that there's no risk for reinfection. Provided that every single one of those criteria is fulfilled, I would say that treatment's not required. Otherwise, I would say do it. So just looking at a simple case example, and we'll wrap up right after this, is as a public health unit, you receive a lab, a 36-year-old. The lab is CMIA positive, you have an RPR of 1 in 1, and the TPPA coming back positive. Review in IFAS shows that there was a positive lab from around 2 years ago. The RPR at that time was 1 in 8. The patient was asymptomatic. They were staged as primary, as the patient reported negative syphilis labs less than 8 months before, but there's no actual evidence in Connecting Ontario. This individual who resides in Ontario has actually no documented evidence of any previous syphilis testing anywhere, including no negative labs at any point. So this individual was treated just with Ben-Pen-G 1 dose at the time. So what you have here is a few different issues, one of which is you can't be an asymptomatic primary, right? This could potentially be an early latent, and that's possible with the new labs, and right, saying that we have negative less than 8 months ago. However, those labs don't actually exist. And now we have a situation of a woman who is pregnant, who has a new lab that's coming in. We do have an RPR that adequately fell, but you're still at a risk of undertreatment here, because this could have in fact been a late latent case, right? And may still be due to the fact that it's untreated. Knowing that we still have that potentially less than 10% risk of transmission, onward transmission with late latent syphilis, this woman in the prenatal case is in fact potentially at risk still for a transmission and a congenital syphilis case. So the takeaway from this, and just skipping ahead to the actual final summary, is as public health nurses, as individuals in the clinic, do use your clinical judgment, right? Put the situation together to say the stage that was received in the investigation form that was provided by a clinical provider, if the stage and the information and the labs and the history don't make sense, right? If they don't align with what we all know clinically about syphilis, it's important to actually ask more questions. And I think this is important because as we move toward more women, more pregnant women, more risks of congenital syphilis, we need to be looking at these items to say, okay, is this person actually adequately treated? How confident are we that this was primary, particularly if it's asymptomatic? And some of this is just a misunderstanding of what we're really looking at. So remembering, epi has changed. Treatment flows from stage. Treatment's pretty simple as we went through that. Use bendazine, penicillin G over doxy when possible. It has a faster cure rate, lower failure rates. Treat contacts, prenatal cases, persons with inconclusive labs. In many cases, it's required. Offer HIV testing and PrEP, and really rely on your clinical judgment, right? As a health professional yourself in many cases to say, okay, does this make sense? Should we be asking more questions? And so with that, I am all done, and I'll pass it back to Laura.
Thank you so much, Andrea and Patrick. We will now move on to the Q&A pod to address some of the questions. So please continue to enter your questions into the pod if you've not already had an opportunity to do so. So the first question I'll maybe direct at Andrea, and it's a comment about in IFAS, staging may not capture all true infectious syphilis cases. As Patrick mentioned, healthcare providers sometimes diagnose and treat as late latent and err on the side of caution and overtreating. I wonder, Andrea, has there been any changes in the rates or numbers of late latent cases of syphilis that you're aware of?
That's a very interesting question, and agree that as Patrick just nicely illustrated, it's important to use some additional clinical judgment and interpreting the labs and the information that you receive from the clinician to determine how you will manage that individual from a public health perspective. We typically don't, only infectious syphilis is reportable. So we don't routinely analyze data on late latent. We usually just focus on the infectious syphilis stages, so the primary, secondary, early latent, and infectious neurosyphilis. So unfortunately, at this point, I can't, we could definitely look at what's available in IFAS if we do have cases that have been entered as with that staging, but at this point, I don't have any additional information.
Okay, thank you, Andrea. The next question is for Patrick. Is there any cross-reaction with monkeypox and syphilis serology?
Thank God, no.
Okay, thank you. And the next one as well, maybe for Patrick and Andrea, if you're aware of any reasons behind the increased trend of syphilis cases that have occurred over the last 8 years or so since 2013.
I can take a stab at this one. I think it's a combination, 3 or 4 factors. Syphilis is hard to recognize clinically. It shows up known as the great imitator. It shows up as a variety of different things. So people don't necessarily know either as a patient or as practitioners that they're looking at syphilis. Second was somewhere around the year 2000, the CDC told us we were going to eradicate syphilis. And most medical and nursing programs stopped teaching about syphilis because they said it's going to go the way of smallpox. So not only do practitioners not recognize it, they don't recognize it because they were never trained. Next, it's really easily transmissible, 30–60%, right? So you have an infection that you're not going to recognize, that you may not know that you have, that your practitioners don't know exist. They're not entirely certain how to test for. It's really easily transmitted, and we end up in almost this perfect storm where we naively thought we would get rid of something, and in doing so, we potentially laid a situation for a rapid outburst, and that's, I think, where we are.
Okay, thank you, Patrick. Next question is regarding PrEP, and if there are any programs to offset the cost of PrEP for low-income patients.
Absolutely. So there is, so the lab itself, if you do get the chlamydia rectal lab results back, it's going to refer you to a website, ontarioprep.ca. On there, there's a PrEP Start program that is actually co-run through the Ontario HIV Treatment Network, which is a research sort of government. It's a research agency that's run through the AIDS Bureau. So it's through the Ministry of Health. There is actually, it's called PrEP Start, and through Maple Leaf Pharmacy in Toronto, they will provide 3 months free to anyone anywhere in Ontario. So this does exist, and it is an MOH program that's there. So you can look up, it's just ontarioprep.ca, and it will go through, and there's a tab that says I'm a healthcare provider. It will give you clinical information on how to do it. It will also give you the prescription that you fill out, that you fax to Maple Leaf in Toronto, and they will mail to any patient anywhere to initiate PrEP.
Great, thank you, Patrick. The next question is around staging. So if a client is asymptomatic, no previous tests, but has a high titer, should we stage as late latent or early latent? And how do public health units stage?
You can't stage based on the lab. You're going to have to get the history. Did the person have a rash? Did they have lesions? Are they a contact? The lab in and of itself, you can't use to stage.
Okay, next one is for Andrea around data capture in IFAS. And so the question is, if we treat conservatively for late latent, but believe the syphilis is actually infectious, how should we capture this in IFAS?
That's actually a very good question. We would have to refer back to the case definitions that are available in the Appendix B of the ID protocol for the province to see, again, as Patrick mentioned, not just relying on the lab, but also on some of the clinical presentation and history to determine whether or not, if you are treating that individual as potentially having early latent infection instead of late latent, then if they meet the criteria outlined in the case definition, then they should be entered or captured in IFAS as an early latent case.
Great, thank you, Andrea.
An anecdotal, non-endorsed piece to that. I would love to see, as they have in the United States, that we have an unknown duration. We don't have it currently, and nobody can actually use it. But there's many cases where it's latent syphilis of unknown duration. You're not sure which way to go, and the benefits to what we really have is the unknown duration is you give the most treatment and you do the most case management, right? So it's you can't be wrong because you give 3 doses, but then you treat like it's late latent, but you follow up like it's infectious. But we don't currently have that as a case definition. So there's not much to be done with it, but that is at least a clinical strategy that you can do to say, treat so you can't be wrong, do case management like you can't be wrong, but then it comes into how do you actually data capture that.
Great, thanks, Patrick. Question for Andrea about whether perinatal infection information gets pulled at all from born or not. I don't know if you're able to address that, Andrea.
No, we haven't used born data for our routine surveillance. It would be something that we would definitely be interested in exploring, being granted access and having access to that data to further be able to describe our congenital syphilis cases, but at this point, we haven't yet had the opportunity to utilize the foreign data to supplement what we have available to us in IFAS.
Thanks, Andrea. Next question is for Patrick about whether there's any risk of penicillin resistance with syphilis, given increasing rates and potential for undertreatment.
Really no. Penicillin has always been the preferred treatment for syphilis, and there has, to the best of my knowledge, never been a documented case of resistance. For whatever reason, it just dies without resistance. And let's hope that continues.
Are there opinions about moving towards what other provinces are doing for maternal syphilis screening, such as Manitoba, and doing third trimester rescreening for syphilis? You kind of mentioned this, Patrick, around there are some existing guidance for screening those at high risk. I wonder if you have any additional comments about doing that more universally.
So the antenatal record that's endorsed by the Nurse Practitioner Associations, the CPSO, the Canadian Medical Association, says to do it at baseline. It says if there's any indications to repeat in the third trimester. So that is actually the endorsed antenatal record across the country. So with any concern anywhere at any point, you should be doing this. Manitoba, interestingly, is actually moving toward recommending screening in every trimester, which is over and above. And it's not a bad strategy, particularly if you have somebody who has any risk factors. But that is already a Canadian standard.
Great, thank you, Patrick. So we are out of time. So as we wrap up today's PHO round session, I'd like to thank Andrea Saunders and Patrick O'Byrne for presenting. I would also like to thank everyone who joined today's session. It's great to see such strong virtual participation. After rounds, you can expect to receive the brief and anonymous PHO round survey for today's session. Please try to complete this to help improve our programming. Lastly, to access PHO rounds presentations and view confirmed upcoming presentations, please visit PHO's website, head to Education and Rounds, and click on Presentations. Thank you and have a wonderful day.